And at the end of the day, you'd like to know, what do I have and what's driving it? What's most predictive, what's most valuable, what's real disease look like? Once you know what you have and what's driving it, you have options.
It's doing a lot of damage. And when you find out that you're sick, you're like, well, what's causing it? And you don't know until you really kind of observe yourself.
There's a lot of plaque out there that people are unaware of. So let's start with basics. Are you metabolically healthy? Are you metabolically challenged? Do you have insulin resistance? How are your cells processing an insulin signal? Are you showing the systemic signs of insulin resistance syndrome? Do you have a lot of these particles that are part of the process of accelerating blockage formation? All of these are important pieces of information, and at the end of the day, what I really want to know is, and what are my arteries up to? Oh, I'm laying down plaque already. We ought to do something about that. And we ought to go, rewind back to the beginning. What are the drivers that we have identified that are just your major risk factors? Is that sufficient? Did it work? Do you need some medication help? That's a better quality conversation, and that's something that Matt and I have worked to operationalize so that docs in 15 minutes can start with a highly personalized report and say, I've got the answer in my hand now. Let's start with that conversation rather than just trying our best without that information.
Hello, and welcome to Legends of Longevity with me, Joseph Entz. I'm your host, and I'm thrilled to have you join me on this journey towards living a longer, stronger, and more vibrant life. The podcast is about uncovering the secrets to longevity, things your doctor does not tell you, whether it's groundbreaking advancements in heart health, lifestyle tips to keep you thriving, or inspired stories of people who've defied the odds. Together, we'll explore the tools, techniques, and mindset shifts that can help you unlock your fullest potential. Whether you're here to learn how to enhance your well-being, support your loved ones, or just stay ahead of the curve in health and wellness, you're in the right place. Let's empower each other to not only live longer, but live stronger. This is Joe with Vasilabs with Dr. William Cromwell. We will have more guests coming, but right now we're starting out with some shop talk about carotid IMT. We've both been doing this for at least 20 years.
Yeah.
We're talking about the old machines we've been using, the upgrades on the machines, and just kind of warming up for this conversation. But we were talking about how you measure the carotid IMT. Should it be in millimeters? I think everyone wants to get to cubic centimeters, like get a full rendering of the artery, which I think we're getting close to, digital. So you could give a patient cubic centimeters. It's getting there.
Yeah.
What else would you like to see? Like, I'd love to add flexibility to the artery. That would be pretty predictive, help people get a better grasp.
So, I think we start with just good imaging. Let's start there, and that should not be underestimated because, as you know, there's a lot of time that it takes to freehand through the bulb, the ICA, the ECA. You see areas that are thick. You need to image it in multiple planes of image acquisition. You need to confirm that it's more than 1.5 millimeters to be a clinically significant plaque, over 2.5 to be next level plaque. You can look at plaque scores and how many total plaques do I have and how many segments imaged. All of that's good stuff. And then you can talk about plaque volume with some of the newer software. You can talk about plaque composition. All of that's good. But so many times, people will bring in what I call a screening type of ultrasound where they're giving some mean IMT thickness, really very little detail of areas of concern that have focal thickening. A step removed from that are duplex scans that are giving you percent, potential of plaque based on flow limitation or flow velocities, and they're saying based on flow velocity, I am there to be a 25% cross-sectional narrowing. And as you and I know, it really is the presence and magnitude of plaque, which is most predictive of event risk. And that's really what people have to, I think, get their arms around, is that you can image plaque, and you can image plaque in a variety of ways, not all of which is very sensitive. Certainly, well-done carotid imaging is very valuable at a young age. You can be thrown off by a zero calcium score. It happens all the time, especially in, say, a under 48-year-old person. A zero CAC score means very little to me, especially if you can image a carotid and show me multiple early plaques. That's disease. Right. and now we can do something about it. So, you and I have been at this for a while, and that's really, I think, the point where folks may have some noise to kind of sift through is, what's most predictive, what's most valuable, what's real disease look like.
Right. About the calcium score, some techs and I were talking, and we were both saying how, I've had a few people I know that I care about had a calcium score of 300, 400. And when we look at their arteries, they were mostly clean. Now, having said that, research came out saying 90% of America will have a plaque that you can point to and show them, and they won't argue. It's a plaque. It's a little bumpity bump in the artery. And I think it's fascinating that I was telling people internally, 80% of the people I scan, but I guess in the American population it's a little bit worse, that so many people have a plaque and they just don't know what to do about it. They don't know what therapies to start, and they don't really know what started it. And my experience was pretty crazy because I've been doing this for 20 years. I go to the conferences, I see what the docs say, and they say when a plaque shows up in the artery, it's kind of like a pregnancy test because it's only going to grow. It's only getting worse. So I'm scanning myself, checking out some equipment, and I saw some little plaques in my artery, and it's game time. So now I'm looking, and I think this may benefit other people because I'm trying to get rid of mine. I do have access to the best in medicine, the best doctors, researchers, and I find myself taking supplements because I don't trust the statins. I mean, they have a certain purpose. They got a great place. But yeah, tell me what you think is going on with healthcare for heart attack and stroke.
Well, that's a big topic, and I guess you can break it down in pieces. Let me pick up the thread where you started, and that is there's a lot of plaque out there that people are unaware of. And I like the pregnancy test analogy. What I tell folks is you've got a process that's turned on, you want to turn it off. So if something is turned on, we need to find the moving parts. And the moving parts are what is different today than it was when I got started 35 years ago. Back in the late 80s, it was major risk factors. How many do you have and what bucket do I put you in? You're a high risk, intermediate risk, low risk by virtue of the number of risk factors, and yet those groups are very imperfect, and people in a designated category may or may not actually have the risk inferred by the number of risk factors. So we've gone from that to a more precision approach where I think the guidelines are attempting to wrap their arms around a variety of data, which include not just major risk factors, but risk-enhancing factors, the presence of imaging studies to demonstrate the presence of plaque, and at the end of the day, you'd like to know what do I have and what's driving it. Once you know what you have and what's driving it, you have options. And I think we're doing next level work when we take the guardrails off and say, of the 35, 40 risk-enhancing factors, what do you have? With respect to your arteries, do you have plaque or not? I have an LDL cholesterol of 120. Should I care or not? My triglyceride is 200. Should I care or not? There's more to the story there. Yeah. And if we're following what I would call the harmonization of guidelines, both European and U.S., what you'll take away from that is there's a lot of detail that we can integrate if we take the time to do so.
Huh. So when you say risk factors, and welcome Matthew, we'll
hey Joe, good seeing you.
Anytime. We're talking about heart disease, what everybody loves chit-chatting about.
Yeah.
But your risk factors, I assume you're thinking hypertension, lipidemia, obesity, your big ones, right? And then your risk-enhancing factors, what do you count those as?
So if we look at the first rendition of this back in the Framingham days, we're talking about age, gender, total cholesterol, HDL cholesterol, blood pressure, glucose. That's basically the major risk factors as Framingham would have teed them up. Now what we're talking about with risk-enhancing factors are how many atherogenic lipoproteins do you have, ApoB? How much LP(a) do you have, the worst of the ApoB particles?
Oh yeah, that's
Do
a
you
bad
have
one.
clinical conditions that confer risk independent of the major risk factors? And there's a whole list of them, from metabolic syndrome, chronic kidney disease. In females, have you had preeclampsia during pregnancy? Are you a lady who's had premature menopause? Do you have erectile dysfunction? Just a whole list of things that are part of the fabric of atherosclerosis and event risk that don't sum up in the traditional major risk factors.
Fascinating. And would you say most primary care docs just don't have the time or wherewithal to put this together, or does it just take time? And that's most doctors don't have.
Well, it is. It's a real problem. So I've worn many hats through the years, right? I've had a clinical lipidology practice for a long time. I've been in academic medicine. I've been a researcher. And what's now happening is we're trying to do the best we can with limited time. Time is my best tool. You give me an hour with a person, I can do a lot of good. You give me 15 minutes, it's going to be tough. You give me 15 minutes with no tools, and it's my best guess. And that's where we are, is that people are using their best clinical acumen in a short period of time with few tools in front of them. And what I was motivated to do with Matt is to say, we can operationalize this conversation that we just started with, the greater landscape of atherosclerotic risk enhancing factors, imaging, major risk factors, taking a step back and looking at insulin resistance, integrate all of this into an individual result and say, Joe, here's your study. Here's what is happening in your body. This is what you need to know. And now you're empowered with a great level of detail to say, I didn't know that. I've got stuff that's turned on that I want to turn off. What are the moving parts? Let's have that conversation. What can I do short of a medication to make a significant difference? Maybe a medication I need, but that's the last step, not the first step, right? Yeah. So a lot of these are parts of the conversation, and folks may or may not have that. They may see their doc, who's a great person, who wants to do the best they can, and in 15 minutes with several problems they're trying to simultaneously address, they say, oh, and your cholesterol we ought to do something about that. Here's a prescription. Well, that might be the right answer, but there might be more to the story as well, right?
Yeah, a lot of times the only thing a doctor can do is give them a prescription in that 15 minutes.
Yeah.
Whereas what you're saying is some education, pointing out what are the really nefarious foods, what to avoid, what to look for, what you want to move towards. I mean, with my bad experience, like I found these plaques and I'm like, all right, game's on. I've got to change some things. Mm-hmm. And the first one was seed oils. Like, I read that McDonald's switched from tallow to cottonseed oil in the 90s. Malcolm Gladwell wrote about it in his book, how everybody doesn't like the new flavor. The tallow tasted better in every metric. But the Crisco is so cheap. It's so easy to clean, so much better than the tallow. It's so much less work that it was worth it to all. So every fast food joint in America uses Crisco or some variant of it, which doesn't burn. It's industrial level stuff, and your body does not digest it like you think it does. And so when you look at pictures of America at the beach from the 1970s, and you look at us today, there's a big difference. Seed oils, corn syrup. I call that Japan's revenge because they industrialized that process. But it's doing a lot of damage. And when you find out that you're sick, you're like, well, what's causing it? And you don't know until you really kind of observe yourself.
And you can ask questions and say, well, let's start with basics. Are you metabolically healthy? Are you metabolically challenged? Do you have insulin resistance? How are your cells processing an insulin signal? Are you showing the systemic signs of insulin resistant syndrome? Do you have a lot of these particles that are part of the process of accelerating blockage formation? All of these are important pieces of information, and at the end of the day, what I really want to know is, and what are my arteries up to? Oh, I'm laying down plaque already. We ought to do something about that. And we ought to go, rewind back to the beginning. What are the drivers that we have identified that are just your major risk factors? How can you address that with therapeutic lifestyle changes? Is that sufficient? Did it work? Do you need some medication help? That's a better quality conversation, and that's something that Matt and I have worked to operationalize so that docs in 15 minutes can start with a highly personalized report and say, I've got the answer in my hand now. Let's start with that conversation rather than just trying our best without that information.
Yeah, I really dig your report. Can we'll put some graphics up of it. But why did you design it the way you did? What were you trying to point out or accentuate?
Well, it's the synthesis of 35 years of work. It's me saying if I go down a fiery plane crash, I don't want the stuff rattling around in my head to go down with me. So at the end of the day, what really motivates me is can we do the right thing one person at a time? That's very different than population medicine. Population medicine is I have 1,000 people like you. If I do something to those 1,000 people, some will get better. I hope you're one of them. That's population medicine. Precision medicine is we know the disease well enough that we don't have to paint with a broad brush. We can be more detailed as to what's going on. So when you look at the data in aggregate, what you find is there are certain things that have stood the test of time that truly are significantly independently predictive and drive the disease. So the first thing I wanted to do was to harmonize the guidelines from the European guidelines, the US guidelines, specialty guidelines, and say, what do we all agree on, number one? And we're looking at it from slightly different perspectives, but kind of what's true north as viewed by experts internationally. Number two, with the fewest number of biomarkers in hand, how can I do the best job? I don't need 20 tests if one will do. And so the challenge is not to try to overwhelm people with a Fruit of the Month Club biomarker that has 50 different pieces of information. Let's just stick to basics. What drives the disease? Insulin resistance, dyslipoproteinemia, major risk factors, and if you knew that you already had plaque that was starting, that changes the conversation completely. So let's stay true to the data. Let's go where we don't have a lot of controversy. What's actionable, because that's critically important. It doesn't really help if you find something that's bad and you can't do anything about it, right? So I can tell you have this new best test that says you're in trouble. What do I do about it? I have no idea, but it says you're in trouble. That's not satisfying, right? Versus, Joe looked at my arteries and said, I've got carotid plaque. Okay, well now you've got disease that has started. Let's unpack the drivers of that. And let me tell you that insulin sensitivity or resistance is highly modifiable. We live in a very insulin resistant world these days. And if we can unwind that to get you back to an insulin sensitive individual, much of what keeps company with that melts away. Not all of it, but much it does. And what are we left with at the end of the rainbow? Don't do the bad things. Do the good things. Don't put wood on the fire. Putting wood on the fire is taking atherogenic particles in excess and bathing your arteries in stuff that forms more plaque. Don't do that.
Dude, I don't even know. I have a convincing answer if red wine is good for me or not. Like, science is oscillating so much in all these things.
That's one where there's not a good answer. And when people have tried to pick it apart, it's more than resveratrol. 20 years ago, resveratrol seemed to be the magic constituent of red wine, and if you had more of that, you'd be okay. And then they isolated it and gave it as a supplement to people, and it didn't make a significant difference. Okay, so it's more than just or is it just the behavior that goes along with individuals who happen to drink in moderation? What else do they do? Well, maybe they don't do some of the bad things. Maybe they are adopting other healthy lifestyle habits. So it is difficult to try to take one example and say this is the missing link, but you see a lot, right? Everybody has a story, and at the end of the story is if you get my stuff, you'll do better, whatever the stuff is. It's usually a connect-the-dots story. And sometimes you can just step back and say metabolically healthy people with low inflammation do well. If you don't have a lot of systemic inflammation and you're metabolically healthy, you're going to live longer than the other guys are. You're going to have less disease, fill in the blank, than other guys are, be that diabetes, be that heart disease, be that stroke, be that plaque. There's just been, unfortunately, a lack of emphasis on what a healthy lifestyle looks like and getting people to acquire that at an early age and maintain it.
Yeah, well said. So let's go back on a little bit of a biography on you, Doc. You've got, 35 publications, 7 or 8 books.
Well, so I've been a part of groups that have done a lot of work. So if you look at our group's publications, there's 700 plus of them. And if you go back to the early days of nuclear magnetic resonance spectroscopy to quantify lipoproteins, that's technology that my partner and I developed, Jim Otvos. That company was called Liposcience. I was chief medical officer of that company for many years. We made it our business for 20 plus years to do lots and lots of studies. And the idea was that we can quantify the particles that carry cholesterol in a way which was different and very helpful. At the end of the day, it is how many bad particles you have that make a difference. And whether the cholesterol tells you that story or not is the problem. Half the time it doesn't in healthy people, 3/4 of the time it doesn't in diabetics. And so in aggregate, we did 17 million plus samples, several hundred different trials, including landmark clinical trials, Framingham, Mesa, Women's Health, Jupiter, you name it. 700 plus publications. So we learned a lot. And that was a lot of my professional life was spent in that bench and clinical research realm, seeking to understand disease from the lens of new technologies that allow us to ask next level questions.
Because you started out studying hypertension and lipids, then you got caught up with liposcience, did a bunch of research there, a lot got out. I see that the 35 publications that I could find, like you've been quoted at least 4,700 times on those, that puts you up there, doesn't it? As far as the most quoted guy.
I would say I'm fortunate to stay in one place for a long time. So if you're lucky enough to find something you like and it turns out to mean something and you can just stay there, then after a while, you just kind of keep chipping away. So I would say I've worked with some really good people. I've been very fortunate. I've had a great run. I still enjoy what I do. I was a physical chemist who went to medical school. And so when I got to medical school, I said, what kills people? Vascular disease. How do you stop it? We don't know. Got some ideas.
Not at all back then.
We got an idea. These things that carry cholesterol might be important. Hey, you measure those things, right? Yeah, well, that's what I'll do. And so you're a nut. Nobody just does that. Well, why not? You just told me that it might mean something for the number one killer of Americans. I should do something like that.
That seems totally reasonable.
So that's what I did, and I just stuck with it.
Fascinating. And the question I really want to ask is, if you could explain to a kid, like just got out of medical school, and you want to cram 35 years of, we were chasing the ball on cholesterol, and then it went from 250 to 200, and Europe had these recommendations, and when people figured out they could fly to Europe and America and not have high cholesterol because the guidelines are different everywhere, and now we're chasing LP little a more than a lot of the other risk factors we used to go after. How would you tell this story to a young med student?
I would take them back to 1950. Back in 1950, Goffman and Linegan are the guys who figured out how cholesterol got into a plaque in the first place. So plaques have cholesterol. How to get there? It wasn't made locally, so it had to be transported. Well, cholesterol is a fat. How do you get fat to float through blood, which is mostly water? It's got to be carried in something. So what carries cholesterol around? Little tennis balls called lipoprotein particles. They're hollow on the inside. They come in different sizes. They have different proteins on the outer surface. Some of them cause a blockage. Some of them try to resist a blockage. That's what we knew in 1950. That was correct. What we also knew in 1952 was you could measure these particles in more than one way. You could measure something that was the particle itself, or you could measure what the particle carries. What the particle carries is cholesterol. But the amount of cholesterol inside a particle can be a little or a lot. It's not constant. So if cholesterol's job is to say, how many of those guys do I have, that's going to be a hard thing to do if the amount being carried isn't the same all the time. So what happened was in the 70s, we basically said cholesterol is close enough. And the way we came to that conclusion is we did studies where we compared people who had really, really, really high cholesterol to people who had really, really low cholesterol. And at the extremes, people did poorly with high total cholesterol. What we didn't do was this next step of saying, Well, if the particle is causing the blockage, how well does the cholesterol agree with the particle? And so if I have two ways of measuring something and they disagree, which one gets it right? Now that little statement is called, in its fancy terms, outcomes in the setting of discordance. When I have two ways of measuring something and they disagree, that's the only time I can tell if one test is better than another. That data consistently, without exception, has always shown the number of ApoB or bad particles is what drives disease and events, and cholesterol has nothing to do with it. When cholesterol disagrees with particle number, it's wrong. So I published this along with other people. The guy who's my senior in this field is Alan Snyderman. Alan's been at this another 15 years than I have. Jim and I came along after him. And whether you read Alan Snyderman's work or Jim's work or my work, what you'll find is a very consistent story. When they agree, cholesterol does as good as particle number. When they disagree, only particle number gets it right. And that is why the answer, am I okay, is how many bad particles do you have?
And you figure out how good or bad a particle is by its density, right? Putting it in that gel and then doing the weight difference? Or how did you measure it with the MRI?
See that's a whole nother conversation.
That's a whole other conversation. We'll get to that later.
Yeah, number and type. All right, so the type is either small and dense or big and fluffy. That's the type. And what we came to understand in the late 80s was this. Let's take two guys who have heart attacks. One guy has a low cholesterol, one guy has a high cholesterol. Well, the guy with the low cholesterol had a heart attack. What else is going on with him? Well, you can do fancy tests with the gel, and you can say, well, he has these small, dense particle at the same cholesterol. So maybe that's the problem. Well, small and dense isn't so unique. It keeps company with other things. Think of it this way. I have a gallon of water, and I have to carry it in something. I can carry it in a cup, or I can carry it in a quart. To carry a gallon of water, I'll have to have a lot more cups than quarts, right?
Yep.
So small means I have a lot of them at the same cholesterol. Now you have to ask another question. If I can measure the size and I can measure the number, does one of them make more of a difference? And the answer is yes. The number makes the difference. The size is largely irrelevant.
Almost like not like an infection.
We identified early on.
Not like an infection, but like they just got more carrier lipoprotein molecules.
Yeah. So the more you have, the more damage they cause. Whether they're large, whether they're small, LDL is LDL. And these types of conversations where there's a lot of controversy really depend on the way you handle the data. What I'm suggesting is that you can do extra analysis by saying, if I adjust the number for the size, the number still predicts.
The number predicts.
If I adjust the size for the number, the size does not predict.
Fascinating.
So it is always back to how many bad guys do you have? Now, bad guys may have black shirts on, but black shirts don't make the problem. It's how many of the black shirts.
Yeah. Fascinating. Like I've scanned thousands of people myself. And you kind of ask them questions. You pepper them while you're asking, you smoke? No. You get your Lp(a) checked out? Like if a patient's got bilateral plaque, I always ask them if they got their Lp(a) because the blood comes bombing up the artery, and like in a stream, the blood doesn't flow evenly. It doesn't split evenly. There's eddies in the stream. Yeah. And you can see those eddies, and that dense Lp(a) comes bombing up and gets caught in these little eddies and gets pushed into the lining, this intimate media that's soft and sensitive and welcoming. It gets stuck in there, and the body doesn't push it out back into the blood. It just doesn't work that. It's got to do all the work from the backside.
Even more than that. I mean, so what binds a particle in the subendothelial space? Proteoglycans. And proteoglycan matrix is more dense and tighter wound in areas of bifurcation and non-laminar flow. So where you have the eddies and where the arteries diverge, you have a meshwork of proteoglycan in the back that is tight like a catcher's mitt. And these ApoB particles, including Lp(a), are trapped in that fabric, which is why you have focal plaque in areas of non-laminar flow and bifurcations, because of this background of proteoglycan, which is not consistent throughout the wall of the artery.
I tell my friends that, and they just don't listen to me, man. Like, you're killing me. So how does that fit with the glycocalyx? That layer on top of the intima that's got little hairs, little cilia, and it's so small it doesn't show up on anyone's drawings.
Yeah. So, transcytosis is now the model for how particles move their way through. For a while, we thought it was passive diffusion. You just kind of get to where those junctional interfaces are between cells. You just kind of work your way through there. Now, there's actually an active transport transcytosis system whereby these particles are able to make their way through. So the ability to get through is one story. The trapping on the other side is another story. I tell people, LDL particles are like waiters in a restaurant. They go into the kitchen, they come back out. They go into the kitchen, they come back out. They get your order, they go get your food, they come back out. It's all good so long as they're, moving on both sides. But if they get stuck in the kitchen, you'll never see your food. You're done. You're just going to be hungry all night. Well, when these particles get stuck in the proteoglycan layer, they got nowhere to go. And that's why they become substrate for macrophage ingestion, foam cell formation. Activated foam cells are the committed step of atherosclerosis. So they got to eat something, and the things have to hang around long enough to be eaten.
Yep.
And the process is that they get trapped in these proteoglycan webwork, and that's the real problem.
Can you spell that? Protoglycan?
Proteo, Proteo, proteoglycan.
I got to read more about that process.
Yeah.
So there's some sticky ectoplasm that grabs those molecules and brings them in.
Well, it's the scaffolding that basically allows the arteries to remain open between pulses, right? So, veins are not so rigid, and arteries have more structure to them. So why doesn't an artery kind of collapse in between pulses as a vein does? Well, because it's got stuff that kind of reinforces it that helps keep it open, part of which is this meshwork of proteins called proteoglycans.
Are there any levers you can pull to make it less sticky, more sticky?
Not that we know of. The stickiness is actually the process of how many are getting in, and by mass action, some are being held. Now, I will tell you this. The binding of particles to the proteoglycans, the pKa, the strength of binding affinity, is different for some particles than others. Lp(a) is very sticky. It's very sticky. It doesn't let go. Some particles have to be oxidized after they're stuck to be most injurious. That's true of LDL. Remnant particles don't have to be oxidized. Once they're stuck, they're game on from the get-go. And remnants are usually in fairly low concentration with a few exceptions. They are not the majority of ApoB-containing lipoproteins, so we don't have remnant abnormalities as often as we just have LDL abnormalities. But I will tell you that once you get stuck, if you get oxidized, LDL is bad. And if you're a remnant and get stuck, you're bad from the get-go.
A remnant, is that like just a broken piece of what?
So when you start out with ApoB-containing lipoproteins, there are two pools. One pool comes from the liver called VLDL, and one pool comes from the gut called a chylomicron. These are very large triglyceride-rich particles, and they are degraded sequentially by an enzymatic process, lipases, that will chew up triglycerides, and like air leaving a balloon, the fragments of triglyceride leave the particle and it shrinks in size. So what's left as the triglyceride is liberated is more and more cholesterol. So an LDL particle is the end result of chewing up VLDL particles. So between a VLDL and an LDL are these intermediate species called remnants. Remnants are usually cleared very efficiently by binding to either an ApoE receptor or by continuing to go through the process of being chewed up into LDL, one of the two. But if you have a problem where you don't get rid of remnants and they hang around for a long time and their concentration increases, now you have a remnant abnormality such as type 3 dyslipoproteinemia, and you're in real trouble because those people get lots of blockage very early.
Super sticky.
And so that's like
Traffic
2%
jams.
of the U.S. population, thank goodness, it's not super common. And yet, I see these people, they present with lots of plaque and lots of vascular beds at an early age. And the phenotype is their total cholesterol and their triglyceride mirror each other. 200, 200, 300, 300, 400, 400. That's kind of the phenotype. When you see that, you think, I wonder what I got. You can do some extra tests and you find these remnants and say, oh, I found your problem. And you know what the solution is? Don't have much VLDL in the first place. If a remnant came from VLDL, if I don't have VLDL, I can't make a remnant. Therefore, shut down VLDL, you can't make remnants.
All right, convince me that diet does not affect my cholesterol, please.
Oh, it does. But how much does it? That's the question. And what you want to know is why your cholesterol is high in the first place. Did you make too much? Did you not get rid of what you made, or both? The answer to that question has a lot to do with how much diet will help you. So if you are overproducing cholesterol-rich particles, diet has a significant benefit. If you don't clear your particles well, diet has potentially less benefit.
So some people generate too many. Some people can't clear out that many.
That's right. So to a lipidologist like myself, we think of production and clearance. So whatever you have a lot of, you made too much, you didn't get rid of it, or both. And once I can figure out how much of each process is going on, then we can tailor your therapy, starting with lifestyle, to see what we can do to help you. Sometimes it makes a huge benefit, sometimes it doesn't. And if it's not because it's a clearance problem, you're going to need a different strategy to clear because your production axis is okay.
How do you test for that?
Well, that's a clinical diagnosis. That's where you look at insulin resistance. That's where you look at comorbidities. That's where you look at triglyceride. That's where you look at a variety of things. And you can tell clinically by a variety of things the likelihood of having either a mixed overproduction clearance defect or a primary clearance disorder.
Fascinating. So I keep hearing that rumor that my diet doesn't affect my cholesterol. It does to some degree, but not to the degree we thought. Or can you clear that up for me?
Some people, it's massively important. So I'll give you an example. Let's say you are an insulin-resistant, sedentary, overweight individual with a triglyceride 300 plus, an HDL cholesterol under 30, and a glucose of 110. Diet is critical for you to get better. You will not get better with medicine. Medicine may help you, but until you clean up your lifestyle, you are going to have a hard road to hoe.
Is that too many carbs?
Huh?
Is that a too many carb diet?
That can be a carb-capped diet. It does not have to be a keto diet. That's a whole different conversation. But capping carbs, improving your overall metabolic health, improving insulin sensitivity is what you're seeking to accomplish. And once you have done that, many things have improved, including your ApoB, including your cholesterol, including your triglyceride. So many of those things packed together. Now, let's say we take somebody who looks like Joe, and he's a healthy guy, he exercises a lot, he's insulin sensitive, his cholesterol is a little high, he diets, and it doesn't do much. What's wrong with that? It's primarily a clearance problem at that point. You're not clearing the particles well, and your diet has a minimal impact on clearance. It has a much greater impact on production.
Okay. So people who don't clear or aren't clearing, their diet's not going to fix it.
So what they need is more LDL receptors. And you can get some of that with dietary manipulation. For example, if you have soluble fiber or things that will bind cholesterol and sterols from your gut so they're not absorbed, that will help because that upregulates LDL receptors. The effect is not significant in some people, but it can help. right?
So some people like Mucinex or whatever would work. Some fiber would help.
Metamucil, yeah, so Metamucil, Gorgum, various soluble fibers can be of some assistance, about 10% reduction.
Huh.
But what do statins do? Statins make more LDL receptors. What does
Yeah, I got to tell
bifidonic
you,
acid
man.
do? Makes more
I've,
LDL receptors. What does
I've got
ezetimibe do? Makes more LDL receptors. So,
I got some clients that are heavy statin users, right? And I see all the
yeah.
studies that go across my desk. And those arteries look bright and maybe a little bit stiffer, and the plaques are definitely more calcified. Like statins do lay down the calcium on the plaques.
Well, so the magnitude of statin effect can be thought of in two ways. One is, what is the magnitude of ApoB reduction and how long did it stay that way? Now, you can look at studies that are statin versus placebo and get a certain amount of information. You can also look at statin plus PCSK9 inhibitor versus statin alone. That's a whole nother level of LDL lowering. So if you look at statin plus PCSK9 and you image vessels, you do cross-sectional plaque volume, you do fibrous cap thickness, you will find that as you are maintaining LDL cholesterols of 30 or less, you are markedly thickening the fibrous cap, you are markedly reducing the cross-sectional area and the plaque volume. So you can regress plaques, you can get thicker fibrous caps, and it does align closely with the magnitude and duration of how much LDL lowering you're getting. Statins by themselves don't get you to that level. So you can thicken, you can stop growing, but you oftentimes will not regress.
Huh. So if I get on a statin, like the rosuvastatin studies, I've seen those plaques shrink like a third. Looks convincing, but those plaques won't go away. Are there any therapies that will remove the calcified bits from the artery?
No. Calcium's there to stay.
Yeah, I used to believe that too.
So the problem is this. When you look at CAC scoring, so my CAC score is X today and Y tomorrow.
It's going to go up.
It went up, I'm on a statin. How much of that is a statin effect? How much of that is my disease getting worse? That's very hard to distinguish unless the number is stupidly high. Like I go from 100 to 1,000. Okay, that's not a statin effect. I get that. But what happens if I go from 100 to 150? What happens if I go from 300 to 400? How much of that is a statin effect? How much of that is disease progression? That modality is very difficult to answer the question. So you'd have to look at something else which is more sensitive. It could be imaging your carotid. It could be a CTA. It could be something else other than a CAC score.
Huh. So tell me about the heart attack and stroke prevention programs that you see that are successful. What do they integrate? What's common amongst them?
Well, the first thing is what's wrong with the person and fix the moving parts. If we simplify this to your major risk factors, we've missed a lot. And that's the problem. There is no guideline currently in use today that says you are sufficient to treat people by knowledge of their family history, cholesterol, age, smoking, blood pressure, and glucose. That is insufficient. You cannot treat people with just that information. You need to know more. So you need to have the risk-enhancing factors. You need to have knowledge of their anatomy, either non-invasively or otherwise. And you need to be able to give a more comprehensive plan of action to address their metabolic health, their lipoproteins, and follow their anatomy over time to see if it's working.
Okay, let's go back to your analogy on how things have changed. In the 80s, it was cholesterol, it was number, and as we're getting better, and back then you got like a 10-year Framingham risk factor, right? Vague as can be. And then in the 90s, it got better. In the 2000s, the imaging came on board, so you could kind of confirm the lipids with the damage aggregated in the arteries. And now you're saying that we can do this precision medicine, this N of 1, pull your labs, figure out what levers to pull and push, and make it. Is that pretty fair?
It is if we're integrating clinical history, risk-enhancing factors, biomarkers, and imaging. All of those need to be integrated. So long as we're doing that, we have taken to the next step forward. So I can give you lots of examples of people who look largely similar. They have similar age, they have similar biomarkers, they have similar major risk factors, and they can be very different metabolically, very different anatomically with non-invasive imaging. So there are other things to consider. I can't tell you how many people referred to me with a simple question, tell me if this person's okay. They have a terrible family history. No man has lived beyond 35. He's 34. And he's got one foot on the banana peel. I just want to know if he's okay, right?
No pressure.
No pressure, right? And so at the end of the day, I'm going to answer that question with what we've been talking about tonight. I'm going to have non-invasive imaging. I'm going to look at his carotids and say, do you have plaque, yes or no? Do you have bilateral plaque, yes or no? Do you have plaque that's over 2.5 millimeters, yes or no? Do you have a carotid plaque score which is over 3? Yes or no? I mean, what's the magnitude of your disease? Tell me about the particles that carry your cholesterol around. Oh, I'm sorry, you have a boatload of the ones that cause blockage, even though your cholesterol is equivocal. Oh, and by the way, you're terribly insulin resistant at a cellular level with an LPIR score that's super high, and you haven't fulminated into full-blown metabolic syndrome yet. But I have found all of the constituents of a problem and early disease, and now we need to do something about it. So no, you're not okay, and if I leave you the way I find you, your future is not bright.
It's bleak.
So now we need to take this information and do something with it.
All right, I got another question that's way out in left field. How did you earn a Bronze Star?
Well, so the funny thing is, Matt, who you've not talked to yet, is a West Point grad, and he knows a lot more warriors than I do. I just happened to be in the theater of operation at a time where there were some opportunities, and Desert Storm was an interesting experience. So I was mobilized for Desert Storm. I was in a MASH hospital that was fairly forward deployed, embedded with 3rd Armor, and so we followed 3rd Armor around, and as we went to the ground war, 7th Corps went straight north. I was in that group. They dropped the hospital not so far from Baghdad. They took a right. We stayed there. There were a lot of casualties. We did what we did. We pulled back to Kuwait, and that was basically most of my story.
Pretty wild experience.
For a young guy, it was a wild experience without having the luxury of everything we've talked about tonight. I had 3 labs. I had a sodium, a potassium, and a hemoglobin. That's all I had. I had no X-ray. I had no imaging. And I had guys who were not getting backhauled. So we had these guys who were in need of help, and they weren't leaving my facility. So 2 and 3 and 4 days now, they were there long enough to have stuff happen. So I remember there's this one guy, he had a bowel injury. So they had resected his bowel. He's in the post-op ward. They're trying to get him out. And I've got a cardiac monitor on him, and he has T waves that are super big, super tall T waves. So, okay, I bet he has a high potassium. Let me do my 3 tests, sodium, potassium, hemoglobin. His potassium was super high, life-threateningly high. Okay, so what am I going to do with this guy? Well, put another IV in him. So I got 2 IVs going. In one of them you put glucose, the other one you put insulin. Let's drive the potassium intracellularly, see if we can get this guy out of the woods. So we got his potassium down to some reasonable level and got him out. That's the kind of medicine I was doing in the desert.
Wild. You ever think, how did I get stuck in this situation?
There were no lipoprotein problems anywhere around. Not a single one. No bird flu, none of that.
Yeah, life was simpler. Wow. So you got home from the war, and then you got right into academia?
I got home, and I went back to work in my lipid clinic, and was teaching at the time. Went from where I was to Florida in the mid-90s to be part of a group called the Florida Lipid Associates, which was one of the first networks of lipid clinics in the United States. I was pretty happy to be there. Thought we would basically stay there until one day I was giving a lecture in Raleigh, and my ride for the day said, "Do you want to meet a man who can measure lipoproteins?" I said, "Well, that would
Yes.
be a good trick."
Yeah.
So I walk into this building. There's this tall guy, kind of disheveled in blue jeans and huaraches, looking at NMR spectra. I said, "What are you doing?" He showed me what he was doing. I said, "So you can resolve downfield shifts that are that small?" He said, "You know something about this." "Well, it doesn't seem like you should be able to do that." "You really know something about this." So we started working together, and I said, "How are you going to do enough clinical trials to see if it makes a difference?" That guy was Jim Otvos. The technology was NMR lipoprotein quantification. We started a company called Lipomed that became Liposcience. And we spent 20 years talking people out of their precious samples from Framingham and any other study we could find to see if it made a difference.
That was a pretty big company for a while. You guys had some reps that were working hard, and I met them out in the field. It was good stuff.
I was the 15th employee of a company nobody had ever heard of before.
Yeah, I've been there too. People heard about yours, though. That was a big contribution.
So, and then, come COVID, Matt and I get together, and I said, "Hey, Matt, I got this issue. Nobody wants to put information together." After LabCorp bought Liposcience, I stayed there as chief of cardiovascular medicine for 5 years. And I tried to convince LabCorp that they should take this information and integrate it into a personalized report. They didn't want to do that.
Not in American healthcare. What are you doing?
So I met Matt, and Matt said, "I can do that." And the rest is this company, Precision Health Reports.
Did it come to you like in a bolt, the idea, the artwork, and putting it all together? Or how did it come to you guys?
I think that's a Matt question.
Yeah, Matt, let's hear it.
Good question. From how to do it, I took what Bill was working on and said, looked at what he had. We spent a large number of hours sifting through. Okay, you've got this. Is this important? Well, it's pretty important. Okay, but do we need to have it? Do we want to have it? The information we were gathering along the way. And then it was a question on each of those data points of where do we get this? Do we get it from the individual? Do we get it from their labs? Do we bring some other data together to figure it out? So we kept working through how do we get the answers to the questions you need to stratify these people, and then okay, once we figure out what we needed to know, how do we then represent it in a way that is digestible and consumable, thorough, but not so much that it runs people off. You get an 80-page report out there. You're overwhelmed. You don't know what to do. It's got a bunch of long words.
Yep.
You're not sure which 5 or 6 pages of that 80-page report is useful. So you just you hand it to your doc and say, "Hey, I don't know what this is. Run with it." What we intended to do with what we built with the Precision Health Report Cardiometabolic Risk Assessment was bring this down to an understandable level that what I refer to as simple infantrymen like me. I was from the Army. Infantrymen are known as your dudes who walk through the woods. We always joke we're not the smartest guys out there, but we'll give it a fair shot.
Yeah.
But something that I could understand and take that and know, okay, participate in my healthcare conversation with my doc. We built this to be something that's a shared decision-making tool, so the individual and their doctor both come to the conversation informed with, here's what's going on, here's where I need to be, red is bad, green is good, here's the target, let's hit the target. Hey doc, here's the target I want to hit. Doc says, okay, great, let's do these, pull these levers and get you where you're going. So really built it out as something that has a lot of information, but in a consumable format that everyone's able to have a stake in improving my health. I'm not out there on my own showing up and saying, well, I'll just do this, and doc's not trying to explain to me, here's what we're doing. Your ApoB. What is ApoB? I don't know. Well, in our report we got ApoB. There's a little hyperlink there that if I want to know what ApoB is, I can click on it and go learn what ApoB means. What are these particles? What do they do? Glycate for systemic inflammation. We have 2 or 3 sentences, but if you want to know more, you click this link, You go learn more about what glyca is and what low-grade systemic inflammation is. And so the information is there, but we really tried to hone it down to a point where it's the best information. It's consumable and usable in a 15 to 20 minute conversation in the clinic. And primary care docs now are armed with a tool that a lipidologist, what I consider a pretty brilliant lipidologist, developed. We've moved that thing forward into a primary care setting.
Yeah, I love your report. It's beautiful. It explains the most important parts as quickly and cogently as possible, and you can always dive deeper. And I had the same idea, I want to think, with ultrasound, that it's just so complicated, and so the carotid IMT, how do I compare to everybody else? And people just want to see a couple graphs. How do I stack up? Am I in trouble? I don't know. Show me. And so you create a nice, beautiful report that lays it out. And the value of that is that if the patient sees it, the light bulb goes off over their head. They're invested. They're emotionally invested. I'll change my diet. I'll work out a little bit. Oh, insulin resistance is too much sugar and insulin floating around my body. My muscles can burn sugar directly. All right, exercise and your muscles get sensitized to that insulin, and the blood sugars will take care of themselves. If you work out, you just got to put to it. And people don't know the mechanics of it. And so illustrating it as simply and eloquently as possible. The doc and I were talking about how a 15-minute appointment, you're just not going to be that successful getting that light bulb off on the patient. And that's why I love my test, the carotid. I can show a patient their artery, and when you show them a little plaque in their neck, they're listening. They're willing to make some changes. So Matthew and I were walking around the Longevity Fest in Vegas, big healthcare conference, 400 booths. I think you said, I make beautiful reports. And that's my line. I make beautiful reports. Explain the narrative to patients in a way that just it's actionable to them. And that's why we're talking, because you guys are doing that for cholesterol. I'm trying to do that for vascular imaging, for the carotid. Because if the patient's not emotionally invested, we're not going anywhere. We're just billing office hours.
So the interesting thing is, Matt is the guy who reeled me in. So the 80 pages is not too far off.
Yeah, you
if
like
I'm
that
write
stuff,
something,
don't
I'm
you?
going to write a lot, right? So I wrote all this stuff down, and he said, okay, too much, and hyperlink. I don't know how many versions of this we have, but what we have now is largely due to Matt continuing to push on me a little bit, which is good. I don't mind that at all. It's still too much. But what we did do that you won't find anywhere else. We asked the question, and here's the process. If somebody was going to get a precision health report, what would they do? Well, number one is they would answer a few questions. And the questions are smart questions. Yes turns on questions, no turns off questions. And it's going to ask you things. Have you had your arteries imaged? Have you had a CIMT? Have you had a CAC score or CTA? Have you had an angiogram? So all of that information is being captured, and it's informing the report. So the report isn't just the best biomarkers that make sense to us. It's your entire clinical history, all the risk-enhancing factors, any evidence of non-invasive imaging that's available, and it's all informing the report. If you don't have, for example, if you answer the survey and say, I've never had my arteries looked at, and the report suggests that you're at risk, it's going to have another page where it says, hey, you might need some non-invasive imaging to look at your arteries. It's going to prompt you to go get your arteries looked at, because that's a critical piece of information, right? So we really want to lean hard into this idea that it is all of the above, including imaging, which gives you the best answer.
Yeah. And you're not going to get this at a 15-minute doctor appointment. I'm noticing huge changes in healthcare where people really do want to dial in and they want to know. And you're not going to get that in 15 minutes. You need at least an hour, maybe 2 hours a year. Mm-hmm. And the good doctors, the private physicians that I work for, they'll have a presentation that they show the patient. Here's your arteries. Yes, there is or is not plaque. Here's your cholesterol. Here's the sticky stuff. Because people, this isn't their specialty. It's not their fault. But you can give them a simple narrative that they can work off of. They can make decisions off of and improve their life.
So I think it would be really cool to take some images, some sort of visual representation. Okay, this is your anatomy. You got plaques. Ooch, I can see them. You got my attention now. That's inside of me. I don't like that. And here's the rest of the story, Precision Health Report. So now you know in great detail what you have and what are the moving parts. And from that, you now have the opportunity to do something different.
So many docs have got these pharma rep narratives in their head, and I can almost hear them now after seeing so many pharma pitches. Like, these guys are just so turned around on what they think they know that it just ain't so. That trying to simplify this and make it as relevant. I'm glad you picked out the risk factors you did.
And what you just said sounded like a Mark Twain quote.
Yeah, just ain't so.
It ain't what you don't know that gets you into trouble. It's what you know for sure that just ain't so.
That's right. What changes would you guys like to see in healthcare in the next 20 years? What do you think will happen?
Well, I think if we were able to continue to integrate clinical history, biomarkers, imaging, and make that the norm, that would be a better quality conversation. I think the second thing is the earlier we get to people, the better they do. The later we get to people, the worse they do.
Yeah.
The sick care system that we wait till you're broken to do something is all backwards. It's upside down.
That system makes the most money, though.
I know, but we need to get to people at an earlier age with more specific information in a more precise presentation and say, when you're 30, it's time to make the changes that will make you a healthy 50, 60-year-old. And if we wait for you to get chest pain and go to the ER when you're in your 50s and 60s, we've missed the opportunity in large part. So we've got to do a better job at an earlier age. We've got to be more specific. We need to integrate all the right pieces, including non-invasive imaging, risk-enhancing factors, so that people can get a better idea as early as possible and make the right changes.
Definitely. How hard is the onboarding for your company, Matthew?
Yeah, it's super easy. So with clinics we work with, we have a fairly simple service agreement that we send to a clinic. It's pretty straightforward. We keep the system up. We keep your data private. You own the data if you want to pull the data out. Simple terms and a business associate agreement. So it takes 30 minutes maybe to read through the agreement, and then from there, the next thing we do is set the clinic up, pop them on our system for an admin in the clinic. Super easy to place orders, super easy to manage through a HIPAA compliant portal. We can have a clinic up in from first conversation of, hey, I want to do this, they can be ordering within an hour.
Are they shipping blood vials to you, or can they go to any location?
They're not. So we have a couple options. So all the analytes we use go through LabCorp. So LabCorp is our lab partner in this endeavor, primarily because their NMR analyses are highest quality. They've already got it in place. The biomarkers we use all come from LabCorp. So it's a very simple panel. Doc really focused on what are the things we need to know. So it's a NMR lipid panel with ApoB or LDLP, LPIR score, glyc-A, lipoprotein A, hemoglobin A1C, and fasting glucose. So it's a very tight panel. They can send the patient to a local LabCorp patient service center for a walk-in appointment. They just show up. 10 minutes later, their blood is out. The blood's out, and they're back in their car on the way home. They can do it in clinic, and
So LabCorp gets you guys the data after the draw?
They do. We pull the data from LabCorp. So from start to finish. If Joe, you're a doc that's a partner of ours, you place an order. For you to place an order, you pop in our system, first name, last name, email address, decide where you want the blood drawn, hit send. The patient then receives an email that says, hey, log in here, complete the pre-assessment questionnaire. That can be done in the clinic, or they can do it on their mobile device, remotely. They get that lab rec, they go to LabCorp, have their blood drawn. Typically, it's the next day, simply because most people aren't fasted, 2 or 3 o'clock in the afternoon. If they get the order done, then they'll wake up the next morning, go have their blood drawn. 1 to 3 days. Their reports in hand. Both the doc and the patient get the same copy, so they're now ready for that next conversation together.
Does the doctor pay for it? The patient pay the doctor? How does that work?
There are 2 different ways. Most of our clinics, the doc pays for it. Some we do patient billing for the physician.
Huh.
So they can pull it through, or have us collect from the patient, we're agnostic either way.
Very cool. Very cool. All right, Doc, one last question. Technology that's been suppressed in your lifetime. This may or may not make the full conversation if it's too radical, but single payer medical system is just devoutly evil, suppressing therapies that do work, that do not work. What have you seen that you wish would have gone a little different?
So I wear a funny set of hats. I mean, I'm a researcher, so I am intimately involved in clinical research. I think the clinical research that we do in the U.S. is high quality and highly valuable. Now, what happens after the data is generated is the question, right? There are data which are generated that never see the light of day. There are data that are generated that are aggregated in various other ways. So I will simply say that, you know, there is the need to have data, there is the generation of data, and there's what do you do with the data once it's generated, right? I think we are in a position where the type of clinical trials that are being requested by the FDA are very costly, they're very detailed, they take a very long time, which means you have to have some funding for that to take place.
Yeah.
Who is going to fund the similar type of experiment with berberine as they are with fill-in-the-blank pharmaceutical agent?
Berberine being a fruit that's free and low cost that helps a lot of people. Who would pay for that? There's no marketing agency behind it?
There you go. Right. So how are you going to get the same type of data for those types of substances? It's going to be very difficult, right? And this is what has happened, is that there's a lot of information that is of the type you can generate on certain budgets. And if you're going to do a full-blown randomized double-blind placebo-controlled clinical trial of the type that is done with the highest level of data, it's going to be much more costly to generate.
Hold on. Are you telling me that big pharma companies will commission 10 or 100 research studies and then only publish the ones that best tell their narrative? There's no way that's possible. That should be illegal.
You know, there's a lot of data out there, buddy. There's a lot of data out there, and some of it.
That's a yes or no.
Some of it I have seen, and some of it I have not. But yeah, there's all sorts of data out there.
How come that's legal? How can it be not like, I know these don't fit your narrative, but there's data here that we're going to put into this big repository that AI will pick apart and give us real finite answers?
Well, see, here's what I will say. The types of studies that answer certain questions are very specific. For example, if you were interested in asking the question, does therapy A versus placebo or therapy A versus therapy B significantly affect heart attack risks, then you're going to construct a study with a lot of people for a fairly long period of time to answer that question. That's a very specific question. Now, as another question, you could say, does it help people live longer? That's a different question. And the number of people you would have to study and how long the study would have to run would be very, very different. So, if I'm doing studies to determine the effect on heart attack risk, I may or may not see a mortality benefit. But by virtue of the way the study was run, I answered the study question, heart attack risk. I didn't power the study to answer the question, did you live longer? That's a different study. So if you want to ask the question, what is the impact of a therapy on mortality? Very different study. And very few studies are designed to answer that question. So we have to be careful of what we expect the data to teach us, given the type of study that was designed and executed.
Understood.
I'll give you an example. 4S, the Scandinavian Simvastatin Survival Study, 4S, 1992, was the first trial designed with a statin with mortality as the outcome.
First.
And it did improve mortality. But the way they did the study was you took people with known heart disease and a baseline LDL cholesterol of 190. Half of them got a placebo, half got a statin, and you waited for 444 people to die. That's the way they did the study.
It's pretty brutal.
So you can do that study and you can get the answer you're looking for, yes or no. But you can't do a study, for example, and say, I'm going to treat people with statin versus statin and Repatha. I'm going to look for a change in heart attack rates. And when the change occurs, I'm going to stop the study and tell anything about mortality. Now, that was called the Fourier trial.
Oh, yeah.
Fourier had 27,000 individuals, a lot of people. Statin, LDL cholesterol, roughly 90. Statin plus Repatha, LDL cholesterol, 26. Marked reduction in heart attacks in a short period of time. So much of a difference that the study was stopped after 26 months.
Repatha.
Would it affect mortality? Nobody will know, because they stopped the study when they hit the endpoint the study was designed to address. So when people say, well, if it was that important, how come it didn't cause people to live longer? Because that was never tested in the study.
Fascinating.
And this is where we get into the mixed metaphors of what do we know and what don't we know, and how do we figure it out.
Seems
So-
like we have the computational power to tease that all apart, though, now.
If you have enough people followed for enough time, but you got to follow them for long enough to determine that endpoint. And when studies are stopped when they hit a certain milestone, and that milestone has not been long enough to determine the next milestone, you have a limitation. And that's the problem with many clinical trials, is they're designed to answer a very specific question, which curtails your ability to find other things because it didn't go long enough.
Yeah, they're cut off.
Unless you do the 4S trial, in which case you say, and we're waiting for 444 people to die, in which case we're going to tell you what happened to dead people. And there were fewer dead people on a statin than there were not.
Yeah. How was the difference on that, though? It was pretty big.
Yeah.
You said
I
90
mean, it was
versus 27.
designed to detect a difference. So as a clinical trialist, I will tell you, I think clinical trials are well done. The trials are well designed. The data are valuable, but they're very specific.
And you throw 90% of them away? Is that fair?
No, they're very specific, but you have to ask the right question with the right study design to get to a single answer. Now,
great care is taken in research studies to make sure we answer exactly what we're asking.
That's right, that question. Now, what about the companion question? I have no opinion about the companion question. That's a different study. And who's going to pay for it? How's it going to get done? How long is it going to take? That's a totally different thing.
Man.
What happens if you have a study where people are non-compliant? They didn't do what the study asked you to do, or their compliance is suspect, so you don't know what to do with the data. That's what you have a problem with sometimes, is that you have studies where there's any number of execution issues on the patient's part or otherwise, where the data collected is equivocal. That can happen.
Yeah.
And what do you do with those data? Well, you don't know. You have to do another study. And this is why it's best to look at the totality of data about a single question and say, if I've done 30 studies and 29 of them say the same thing, that's probably reliable.
Yeah.
If I did one study and I have no confirmation in any other trial, I don't really know what that means.
I was just trying to pull up one study. Like what you said about foods that are super healthy for us, that should be studied more, they're just too hard to turn into money. Like, was it Nathan Bryant, the guy who did nitric oxide? And he figured out beets. Beets have got it in spades. So he's selling beet powder pills because he's got great research. And he's selling them. But, dude, just eat a beet. Just eat some pickled beets and you're there. Like, you don't need a bucket pill. But people don't want to add that to their diet. It's crazy.
Well, so as you've seen, there are a lot of ways that our food industry has been tainted through the years. There's a lot of stuff that's in the food supply in the U.S. that would be illegal in other countries. There's a lot of the quality of our food supply that has gone way down compared to other countries. And so this is its own thing. And
We
this
got bright
is,
Fruit Loops, though. That's very important.
yeah,
We
yeah,
got bright.
yeah. We have toxic breakfast cereals, and people love them, right? But they're basically toxic, and that's true.
Yeah. You think there's going to be a fix for that until the money dries up on the
Well, I mean,
Orgeat
there's a lot of
Nabisco
talk right
tobacco
now, isn't
food?
there? There's a lot of talk right now. We'll
Could
see what
be.
the
Could
talk
be
turns
next week.
into. There's at least somebody who's aware, who's trying to make some noise. We'll see what the noise turns into.
Yeah, I want to be optimistic.
Yeah,
There's a lot of momentum keeping things the way they are, though.
But let's take it back to one of your statements early on. If you are empowered and you understand, wouldn't a reasonable person have a question? What can I do that would make a difference for these things, these goobers that you found in my neck? I don't like those things. I want those things to be gone. And Doc, if you tell me that I'm engaging in behavior that's making those things worse, I don't think I want to do that. I don't think I want to eat my Fruit Loops. I don't think I want to drink my full-fledged soda. I don't want to, yeah,
10 sodas.
yeah.
You know, okay, this one, it blows my mind. The placebo effect. 12 to 20% of every study, they just expect patients, because the patient expects it to work. It actually does work.
Well, so you do have a placebo arm that can show a change. And one of the things that's interesting is, let's say you go down 3%, 5%, pick a number in the placebo arm. And you compare that to the active therapy arm, and it goes down 25, 30%. The difference between those two is a real effect. And I think that's one of the things that we have to see is what is the difference between the two groups, for the reason that you said. It's also true for adverse effects. You're on a placebo, but you make complaints. Oh, I have chest pain now because I'm taking whatever it is you gave me. I gave you an inert compound. Oh, I've been terribly nauseated since I've taken this inert compound. I'm sure you gave me the real stuff.
Adverse. I didn't think of that.
So if you look at drug inserts, package inserts for a medication, you'll see the adverse effects that are in the table. And the placebo arm is here, and the active therapy is here, and you'll see there's a certain number of people who have the complaint in the placebo arm.
Really?
Oh, yeah. So 5% complained of it in the placebo arm, and 7% complained of it in the active therapy arm. So there's a 2% difference. Is that meaningful? So this is what clinical research allows you to do. There's a certain amount of noise, and you have to be able to quantify the noise so you can see how that differs from the other arm.
I'd like you to pontificate of the power of the human mind and placebo.
I think anxiety is a very interesting thing. People get very anxious.
But like these cancer patients that actually get rid of the cancer from placebo?
Oh, that's outside of my pay grade. I don't know. I
That's
think,
something though, right?
I think cancer is really, really complicated. And the guys that I know that are really good in oncology, they take precision medicine to the next level. Now, we talk about precision in terms of details of the individual that are important. They take precision to I want to know the DNA of the tumor so I can tell you what therapy matches that DNA. So your therapy is now tuned to your DNA tumor.
Huh.
And
Does
your
single payer
tumor will
Medicare
change
system
over
pay for
time.
that, or is that private?
That's
get
private.
that?
I mean, so I mean, all those very expensive oncology therapies.
Yeah.
Oh yeah, I mean, there
They're
are
dialed
tests.
right in.
There are tests out there now where if you had I'll pick breast cancer. If you had breast cancer and I got the DNA, I can tell you all sorts of things that would indicate certain therapies more likely to help you than not. And I will tell you that DNA will change over time. And so maybe 3 years from now, if you have a recurrence, you get another piece of tissue and say, oh, your DNA changed. That cancer cell just got smart and it changed its DNA, and it's not sensitive to what you took the first time. You need to be on this time.
Wow. I didn't even know those guys existed with precision level. I know they're
yeah.
getting gut biome profiles for patients, and that's helping a tremendous amount.
Yep.
I know they're getting, your DNA, your epigenetic triggers that they can pull?
So in the future, maybe there's a way in heart disease that DNA can be made actionable. Right now, we're not sure how to do that. We can do a DNA test that says you're at risk. What do I do about that? The same thing we told you the first time. Don't smoke, eat right, stay healthy, exercise. We didn't teach me anything new. Well, I taught you that the deck was stacked against you.
Right. Yeah. Have you heard of natto, N-A-T-T-O?
That's like the bean, the fermented bean.
Yes.
Like a Japanese bean.
Yes, it's the Japanese breakfast. It's fermented soy. It smells like a bucket of wheat left in the barn too long. It got wet. Just
tasty.
Oh, I wish. So I'm at a trade show in Dallas. I got my booth, and there's some muscle heads across the way. 60-year-old hormone replacement guys. I'm not judging. I take it too. But I've scanned enough of those guys that I know they got like 20% stenosis all the time. So he comes over, I scan him, and he's got a couple little specks in his artery. Like, hardly anything. Bro, what are you doing? Oh, I take nattokinase and serrapeptase. What's serrapeptase? It's the digestive enzyme the silkworm uses to gobble its way out of the cocoon. Turns out the serrapeptase plus natto cleans out the arteries. I said, no way. So he sent 4 other muscle heads, and they were all clear. I'm listening. He sends me the research study. It opened up arteries 30-something% in a year, eating natto plus serrapeptase. I want to say I'm a good researcher, so I bought some. I went down to the Japanese food store, not the Korean, not the Asian, Japanese. It's like $1 a meal, super cheap. And I start pounding it, and it devolved into me like putting the beans in and then just swallow it because the taste is not normal for me. But the research on that is so compelling that I'm still doing it. I'm trying to chase away these 2 little plaques I got. But have you seen that research, or is there any other comparable research you've heard of, like miracle level?
Well, the problem
reduction?
is that the type of research which is done is not the kind that we were just talking about.
Yeah.
Right? It is smaller scale in lower numbers of people.
Yeah, this was like 1,000 people. It wasn't that huge.
Yeah, so if it could be systematically studied in the same way you would a statin, that would be something that would add to our understanding. In the absence of that, what do? I think you can take the available data and you can run with it. Is it likely to hurt you? No. Is it potentially beneficial? Yes. How much benefit? Not sure. Not sure we know the magnitude of benefit. And that's the biggest problem with some things is it makes a lot of sense, but it's very hard to attribute a magnitude of benefit with the existing data.
Right? And there's no berberine lobby and there's no natto lobby going to pay for this. But everybody wants to get back to real food, real nature, feeling good.
Well, you're not going to convince Dr. Cromwell that something bad is not going to work. He's a big kefir consumer, and if you've ever had a moment with some kefir, it is an unpleasant experience.
That's wild. Kefir, huh?
I enjoy kefir. Every day I have kefir.
Oh.
I just got into raw milk, and I gotta drive like 4 hours round trip. It's brutal.
You just got to put some of that nice bacteria in there and let it ferment, and life is good. Your microbiome will love you.
That's what I'm working on, is the microbiome.
Yeah.
And those dudes that are doing the transplants, like, they are committed to their cause.
Yeah.
But
So,
they're getting results.
I'm not opposed to things that make sense, that are natural. And for me, I got a lot of joint inflammation. And for me, curcumin and kefir together keep me moving just fine.
Really?
On a bad day before all that, I would walk with a cane to walk the dog in the morning.
Arthritis that bad, huh?
Yeah. And now, no worries.
Kefir and what?
Curcumin. The stuff that's in turmeric, that's the active ingredient.
Noted. That'll be probably the most popular clip from this whole podcast.
They finally got around to something good.
Finally, some food I can eat. Let's go get it. Do you have any thoughts on Arterial or Vasconauts?
In terms of?
Efficacy. I got a lot of docs that use it.
Again, data I've seen are of a type that directionally correct, but what do you make of it? I don't know.
Oh, that is good code word. Directionally correct. Good diplomacy there. Thank you. Not all these sections will make the main blast off. We'll be diplomatic. We want friends. Anything else you guys want to say about your product or the crumbling American healthcare system?
I like the synergy. I'm glad that you've been doing what you've been doing for a while. We have as well. I'm glad the guidelines have thought that imaging is not just for some people; it's an integral part of how we assess individuals. I wish more people started with anatomy and a comprehensive look, as we try to do, with their history and risk-enhancing factors, so they know, eyes wide open going in, what's going on. If you don't know what's up with your arteries, you don't know what's going on.
No, you're flying blind.
You're flying blind. If you know that you have a process that's turned on, you want to know the moving parts that you can turn off. It seems pretty simple to me. And you're not going to get that with major risk factors and putting people in a bucket of, oh, you're high risk, you need a statin. What are my arteries doing? I have no idea. What's the rest of my story? I have no idea. What else can I do? I don't know.
If you got 10 minutes, that's all you can do is put them on a statin. They're not going to change behaviors. They're not going to.
So when I see people, I say, listen, medicines are great. They're mops and brooms. They clean up a mess. If you have less mess to clean up, you don't need a mop or a broom. Right? That's what therapeutic lifestyle does. We clean up your mess, therapeutic lifestyle, and if there's a mess left over, we can talk about getting the mops and brooms out and getting your medicines.
But eating good food, reasonable food, exercising, doing maintenance on your body.
Yeah, I mean, doing the things that are most likely to contribute to longevity and health span.
Yeah. Any foods you think are definitely not in the American diet that we should eat more of?
Oh my goodness, I think our problem is the excess of bad rather than the need for good.
Right.
I think you got to stop doing the bad things before you can start worrying too much about the good things. We've got so much high fructose everything, high processed, refined everything. How many people eat a serving of vegetables a day?
I eat pizza, and the government says that counts.
So I mean, just getting to the basics of don't eat the bad things, eat a balanced, reasonable diet, and then we can start talking about the things that you could emphasize that might make a difference.
But the societal knowledge of even how to prepare food, like everybody's eating out of bags instead of eating a beet.
Yeah. So my wife grilled some chicken tonight, and I had green beans and chicken.
Delicious.
Yeah. What a great meal.
Right? That's all you need. Fermentation and mushrooms or fungus. Not so much wooey mushrooms, but what magic have you heard in those?
Fermentation, good. Kimchi, kefir, all kinds of fermented foods. They have all kinds of health benefits. I think fermentation itself does a lot of good things. There are some societies,
It unlocks or creates new enzymes, or what's the magic of fermentation?
So there are a lot of societies that have very heavily fermented diets, like Koreans. You have a lot of kimchi and other fermented foods. That pickling, as some societies used to pickle a lot of things. Kefir. So all of these are very good for your microbiome. Very, very good.
But with the reduction, like these foods are just not available anymore.
You have to go looking for them, or you have to make them yourself. So I make my own kefir at home every day, have for years.
Huh.
So every other day or so, I strain my kefir.
You make your own kefir? Hold on, I just heard that.
You make your own kefir?
Yes, sir. I've got my kefir grains, and Matt will tell you, he's seen them. I have my mason jar with my kefir grains in there. I pour my whole milk in. I let it sit for about 48 hours. And then I strain it. What's in the strainer are the kefir colonies. That goes into a clean mason jar with new fresh milk. And what's strained in the bottom is fresh kefir that goes into a glass container in the refrigerator to bottle condition for a few more days.
That's what medicine should actually be. Stuff like that. If that cured your arthritis, I won't knock it. But it sounds like a science experiment.
It is.
My eyes are watering him talking about it. Having
Does it
tasted
smell
it.
intense?
Oh.
Well, it tastes intense. Matt's sitting there and his eyes twitching.
It hurts.
To me, no, I'm used to it. It's great. I mean, I even let it do a little bit more than when you were here last time.
Oh, like they get overripe? It's gotta get over.
I let it sit there a couple extra days.
It's going to grow legs one day and walk off the counter.
Okay, here's a question I want to have. I've been looking for somebody to have this conversation intelligently. Somewhere in the 1980s, 1990s, you and I heard about blue zones. People who live over 100 live in these blue zones. They're in the Mediterranean, they're in Japan. And like I felt like science was starting to get there. This narrative made sense. Let's figure out what these guys do. And then they try to tell us they ate seaweed and fish, and that may be part of it, but I was unconvinced. So I dug into it more, and like the Asians have this natto stuff, and they're eating fermented foods, and they're living closer to the earth. The Mediterraneans are eating fish, and the Italians have tons of fermented foods, and they're eating mushrooms and fungus, and like a lot closer to the earth. What do the blue zones, what were we not told about the blue zones that you can figure out?
Well, I think we're still trying to figure it out, right? So the problem is you find differences and then you try to attribute a magnitude of benefit to that difference. I remember there was a time when they were talking about the alkalinity of the water in Okinawa, right? So that was a blue zone. So here are these Okinawans that are centurions, but their water is high pH water, so we need to alkalinize the water because that's different. And there are probably many, many things that are culturally different compared to us, many of which are healthy, but how much of them individually are going to make a difference for us versus it's the entire lifestyle and the entire society and the entire way they live and eat. I mean, how many of these people are up early working all day? How many of these people are obese? How many of these people are eating food, as you said, closer to the earth, not processed, not refined? All of that together, in aggregate, sets people up for success. And I'm not sure we know enough to try to pick a smaller subset of those things out of a crowd and say, oh, well, this is what's missing. So if we did this part of what they do, we could be more like them. I don't think we know that.
Yeah, and you've got other factors like families and high trust society, and those I'm sure make a big difference. But yeah, the blue zones, we were led to believe that there's an answer there, and then kind of like Michelle Obama's eat healthier food campaign, it was disassembled in 6 weeks to eat less, move more.
Yeah, right. So, I guess if you want to really understand the blue zone, then go live your entire life in the blue zone, and then we can see how you did, right? So I don't think in the United States there are too many places left where people are working manually off the land for a living. They're getting up like our great-grandparents did, and they're going to eat what they are out there harvesting and reaping and sowing, and if they want milk, they got a cow. If they're going to eat protein, they're going to catch it, they're going to shoot it, they're going to, it's what you can do on your land with your stuff. That day is gone.
Yeah, you're right. It would take a whole life redesign. But I suffer from solipsism. I don't know what I don't know. I only know what I know.
But, I think it is our psyche to believe that we're largely good if we only did fill in the blank. When in many cases we're largely bad. And filling in the blank isn't going to overcome our deficiencies.
That was a referendum on the American system. That's...
It's the Apollo 13 in reverse. What's right on this ship? Not much. Well, there we go.
That's wild. Any of the things about healthcare that you think are important that most people just don't know or doctors aren't told by their pharma reps?
Matt?
You got me.
Yeah, Matt, you must have seen some stuff in your years.
I don't know. For what we did with pharma before, it was really marketing drugs that already been, proven. They passed the clinical trials. They got to market. The things that we saw in our work with pharma on the distribution side were compliance. How do you get people compliant on medication and keep them going?
Yeah.
It was obviously pharma was motivated because it was a matter of, selling more and as a business, and I get that. But, the reasons people stop medication were varied. My legs hurt, I don't want to take it, it's too expensive. So we were helping most of the expensive issue with what we were doing. But one of the main reasons people stopped taking medicines were because it worked. And so someone's on a statin, and we always obviously back in those days measured LDL cholesterol. Their cholesterol was fine, so I'm good now. I'm cured. I'm gonna stop taking this.
But I'm gonna keep eating the same food and not moving the same amount.
Yeah, and then all of a sudden they're back where you were. And if there's a regret I have with what we do, it's that Precision Health Reports didn't exist when I was 30. Left the Army. It was pretty healthy. Went to work.
Wait, so you got this idea? You took the doc's research and simplified it.
We took his work and made it happen. Yeah.
Who's we?
Doc and I.
You. That's you.
We're a company of two.
We're a company of two. Yeah.
So all the operational things is Matt.
All the wisdom is Doc, and I've just made it work.
Very cool, Matt.
That's kind of how it works. We, working for a fast-growing startup through my 30s until I was 41. Go in early, stay late, have a few drinks after work. You have meals catered in because it was, convenient, and you had to work through things and whatever. And I'll go to the gym tomorrow. I'll go to the gym tomorrow. I'll go to the gym tomorrow. Those things add up to unhealthy things happening inside you. So I'm fortunate to have caught disease at an early stage in my early 40s.
Tell me this story. So you were living your life, working too hard, and you caught it?
Working hard, not working out, eating what was there, and making a fast-growing company grow. We did fantastic, but what you sacrifice in doing that is oftentimes your own health. There's always the parable or whatever of I traded my health for money, and then as you get older you start trading money back for health.
For youth. We traded for youth, not health.
Yeah. And there you have it. So had I known this sooner, I'd have done things different. Would I've had the plaque that Doc scanned in my neck with doing a CIMT? Maybe not. Possibly.
Did I scan you in Vegas?
No.
I scanned him when we started working together. I said, come to my office when I found plaque. I said, look what you got.
Oh, Doc, you found it too. That ultrasound is the best convincer in the whole world. When you show someone the plaque in their neck, they're like, okay, I'm in. You told me my cholesterol is bad, but pooty poo. I saw that plaque and that did not look right. Is that going to affect my penis? And that's where they take off. That's where they get invested.
What Doc did to me was he said, okay, repeat after me. My name is Matt and I have vascular disease. So that was the first day we met in person. We started working together in February of 2020, right in the middle of COVID, and got Precision Health Reports set up. We were running. We did a little fundraise. We had an operational product. All those things. We met in his office in October, and within that first day, he scanned my neck and made me admit I had vascular disease. And I said, "What do I do now?" He said, "Well, do you feel like you're eating well?" So I think so. He's like, "All right, well, you might want to try a low dose statin." And I said, "No, I don't want to do that." And he said, "Okay, we've had a shared decision conversation here, and you've decided what you want to do." Well, fast forward about 6 months or so, I called him on a Saturday morning and I said, "You know what? I need that prescription now. I take supplement. I take a supplement every morning. I take some creatine. I take whey protein, whatever. I'll just treat this as a supplement and take it." And but it took that conversation. It took seeing it. It took me digesting it. It took me walking away and having to kind of, swallow some of my own, I know better there. And now my ApoB is in the right range. And to me at this point, a statin is just part of my daily supplement routine. Get up in the morning, take a vitamin, drop a
You
received
didn't
statin.
try the whole red yeast rice pathway that a lot of patients try to go down,
That's just a statin.
right?
It's a natural statin that's not very well regulated lot by lot. So
You're not
what you get
100%
today, you
sure
know
what you're
get
getting.
tomorrow. Yeah.
Yeah.
Wow. So it hit you, and you're like, when did the creative part start? Like
The
making
creative
the report.
we started talking February, then COVID hit. So then it was a matter of, probably
No way.
middle of March.
No.
I had the exact same timing for my report. Like, it hit me like a bolt out of the blue. I started drawing in a notebook like a madman, and then I hired an artist and like completed it. But right when COVID hit, I got the inspiration.
Yeah.
That's
So I've
amazing.
been working on a version of this for many, many years, and it's had many iterations. So sometimes you know how it is. You get to a certain point in your own creativity where that's about as far as you go unless fresh eyes see it.
Yeah.
So one of the nice things was, Matt wasn't influenced by what got me to where I was. He was able to look at it with fresh eyes, and so that was helpful. It really was. And so, we weren't tethered to anything in particular other than certain working principles. Red is bad, green is good. We got to represent this in buckets. There's a metabolic bucket, there's a lipoprotein bucket, there's a diabetic bucket. We need to integrate, we need to harmonize. And
Yeah.
so those are the principles. Now, how do you make it so that it's visually understandable and people can do something with it? And I'm taxed by having all this extra stuff in my head that I want to get out, and
Taxed.
it's not helpful, right? So,
And I'm fortunate to have an empty head.
So the way we solved this problem was bitty links.
Yeah.
And he told me I could write whatever I wanted to that was linked to a bitty link. So there we go. And then after I wrote everything I wanted to, it was still too long. So then we had to hone that down.
Yeah.
Get links
Everybody
and make
wants
it
a
easy,
tweet.
Yeah.
and then really it was a function as a matter then of how do we take this thing and make it easy to access and easy to use, and make sure it's got all the security and all those things out there that doctors and individuals expect around their healthcare, and make it something that physicians can make easily part of their workflow rather than I've got to go to this thing and get all this stuff and go gather these labs. Forget it, I'm not doing it. So make it.
Yeah, you designed it super nice that a patient can go to one place, the doctor will get the report, and it's clean.
Yeah, they both get it.
That's
The same-
difficult.
Have the same
And all
hymnal. Have same hymnal to read out of when they get to the room there talking together.
And all that programming and stuff that has to happen to get to the nice end product, that's Matt and a design team. And that was all homegrown.
Wow.
That was all homegrown. That's all that coding, everything we own. I mean, that wasn't anybody else but Matt and the design team. Blocking and tackling and proofing and rejiggering. Yeah.
Congratulations. Few people pull off something like that in their life. A real bad term paper. A really well done term paper. Sorry. A beautiful, elegant.
I've come a long way since my actual term papers. I can tell you that.
Yeah, I flunked my way through college. I'll admit it.
But Joe, the thing that still is amazing to me is how many people fill out the survey and they have never been imaged. They have no idea in any way, invasively or non-invasively, what's going on inside of them. And how many times does our report spit out a little statement, you should have non-invasive imaging? It happens very, very regularly.
Yeah.
And so here we are prompting people to say, and you're still missing the how's my artery question.
Yeah, my business used to be sending technicians to offices, rack up 30 patients, we'll show up, we'll knock it out in a day. That was a good business for a long time, but now that these smaller probes are coming out, we can generate it, $5,000 probe, we can teach you how to take the images in just a couple hours, send us the videos, we'll get you an IMT, we'll get you all the plaque we see, and it's just that light bulb. That's the moment where the patient's, I'm invested, I'm in, I believe you. And yeah, imaging it's going to be a lot more common, but right now it's just tough. It's just tough. You needed a $40,000, $100,000 machine, real specialty knowledge. Not many people know how to do that. But luckily, I'm the guy that brings these to parties, and I like showing people their arteries.
You got lots of friends.
Yeah, a lot of pregnant friends too. All right, it's great talking to you guys. Those are all the questions. I'm super happy we got this done. Nice meeting you, Dr. Cromwell. Matt, good seeing you again.
Good seeing you again,
Good
Joe.
to see you. Thanks for your help.
We're doing it. We're going to tell the world how to be better. Just got to know.
Make vascular disease a rare disease. We get it right.
Yeah, it's not right now, but it's not going that way either. But we're trying.
We're trying. Let's get it.
We're trying. God knows we're trying. All right, see you guys. Have a good day.
Thanks,
right.
Joe.
See you.
Appreciate it.
Bye.